بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Ladies and gentlemen, dear colleagues, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to welcome you here today in the 30th IMC Family Medicine Club, and with the participation and a partnership with the Saudi Society for Family and Community Medicine. And I would like to extend our thanks to the organization, which is Multaqa al-Khibrat, and the sponsorship of the GSK. Of course, it has been 4 years since we started the IMC Family Medicine Club. I remember it was 2019, just before the Corona, and we had the first physical event, and then it was converted to be a virtual one. But these 4 years has been enriched with a lot of activities, which has been continuously delivered to all the primary care physician and the family physician. And the topics were always we tried to select those topics which is relevant to the clinical practice, and to that one which highlight the challenges that we encounter in primary care. And we have enriched this scientific event with the participations of our colleagues from different specialties in order to add the value and to have the insight of how we could move our patient from primary care to the secondary level of care with no turbulence. So our aim was to add a confidence to your practice and to carry our responsibility with big competency, responsibility, and commitment as well. Today, ladies and gentlemen, we are going to talk about another important topic, which is chronic obstructive airway disease, which is a very prevalent in our practice, and it's a potential life-threatening of non-communicable disease. In fact, we pay less attention to COPD, while we pay a lot of attention to diabetes, dyslipidemia, and hypertension. Actually, it deserves this kind of interest to know all the details about the COPDs. And as the GOLD guidelines, they said that it's a common, preventable, treatable disease. So we can prevent and we can treat and we can decrease the comorbidities and decrease the consequences of the complications. So our challenge as a primary care physicians in the COPD have three different components. One is the primary preventions in reducing the risk and identifying those at risk of the populations, and the other level of secondary prevention, which is early detection and specific protections of those people who are at risk of getting into COPD. And the third level of prevention is to decrease the progression of the disease and to improve the quality of life of patients who will be having this kind of disease going throughout his life. So unfortunately, in spite of having all the guidelines and the updates, many of us, we are not aware of the recent updates, and we are reluctant exactly to identify what is our role to manage those patients in the early stage. So unfortunately, it is misdiagnosed, underdiagnosed, mistreated, and undertreated condition. That's why it deserves a lot of attentions. And as a primary care physicians, we have to be aware of the early symptoms of the chronic obstructive airway disease, which is cough, chronic sputum productions, and short of breath on exertions. So this is the tool that is very commonly encountered in our day-to-day practice. So without any further ado, I would like to welcome you all here in this scientific event. And I can assure you, inshallah, that we have a varieties of topics that will give you the overall picture of COPD. So we have the role of the primary care physician in COPD management. So this will be highlighted by our dear colleague, Dr. Badr bin Hind. And then we are going to have the COPD current evidence of diagnosis and management by our colleague who is pulmonologist, Dr. Omar Shamma. And then we thought just to get you a real world case scenario, just to identify how the patient is presented to us and how we could manage those patients from the clinical scenario, which will be delivered by Dr. Dalia Filimban, and then the early input optimization in COPDs by Dr. Sultan. So we will be ending our session by the Q&A, which will be an hour and a half from now. So without any further ado, I would like to welcome our guest speaker who has been selected very meticulously, inshallah, to add a value to our presentations and our session. So we would like to welcome Dr. Badr bin Hind, who is a consultant family medicine in the International Medical Center, and he's the chairman of Family Medicine Department and Credentialing and Privilege Committee in the International Medical Center. He is a member of the Organizing and Scientific Committee of the Family Medicine Club and Conference and Smoking Cessation Program. He is well known in the medical community, in fact, and he's the member in the International Association of Medical Education. He's a speaker and organizer in many international family medicine conferences and even the local one. And he was awarded the best doctor and trainer of IMC in 2021-2022. So I'm very sure that the presentation and the highlight of Dr. Badr will add to us a lot of values. So on behalf of all the audience, Dr. Badr, I would like to welcome you. Thank you for accepting the invitations, please.
Assalamu alaikum jameen. Thank you, Dr. Rajab, for your introduction. Thank you for the organizing committee for organizing this scientific meeting. Inshallah, I hope it will be a fruitful and presentation, and I hope the presentation in the coming 20 minutes will meet your expectation bi'idhnillah. So this is my objective for today. I will start with a small introduction, then we will have an overview about the definition of COPD, then we'll talk a little bit about the pathology and risk factor, and after that we'll follow that by discussion about the complication of COPD, what are the clinical features of COPD patients. And we will discuss the importance of screening. Should we screen a patient with suspected COPD or not? What is our role in family medicine to screen or not? So what's the evidence behind it? Then we'll go and move talking about the approach. In family medicine, we always like to talk about the approach, how to approach patients with suspected positive or symptoms of COPD, following by talking about highlighting the diagnosis. I will not go in detail about the diagnosis, staging, and management. Just I will give an overview about diagnosis, staging, and management. I will leave the details for our colleagues the next two lectures or presentation, inshallah. So COPD is a common respiratory condition, as we know, characterized by airflow limitation, and this is the hallmark of COPD. It affects more than 5% of the population, and it is associated with high morbidity and mortality. Also, it is the fourth ranked cause of death in the United States. Sorry. Establishing a correct diagnosis of COPD is important because the appropriate management will decrease the symptoms, will reduce the frequency and severity of exacerbation, will improve health status and improve exercise capacity and prolong survival. And the most important thing, we are seeing many suspected cases of COPD in our clinic. The most important thing is to improve the quality of life for our patients. So what is the definition of COPD? So COPD is considered as a preventable, treatable, and chronic inflammatory lung disease that causes progressive airflow limitations that is due to airway and or alveolar abnormalities, which is not fully reversible. Emphysema and chronic bronchitis are the two most important conditions that contribute to COPD. So the chronic airflow limitation is caused by chronic inflammation, which cause a mixture of small airway destruction. So we are talking about bronchitis, parenchymal destruction, we are talking about emphysema, and mucociliary dysfunction, which is a characteristic feature of the disease. So as we can see here, this figure, I will showing the emphysema and chronic bronchitis in a suspected case of COPD. So generally, always we are mixing what is COPD. So COPD, we should consider COPD as an umbrella, and three main components that contribute to COPD, which is chronic bronchitis, emphysema, and irreversible or refractory asthma. So COPD is a group of lung diseases that make it hard to breathe and to get worse over time. So there is interrelationship between asthma, chronic bronchitis, and emphysema, and the hallmark and the main feature here is airflow obstruction. So talking a little bit about chronic bronchitis first. So chronic bronchitis defined as a chronic productive cough for 3 months in each of 2 successive years in patients in whom other causes of chronic cough have been excluded. What about emphysema? It's a pathological term that describes some of the structural changes in the alveoli. So these changes include abnormal and permanent enlargement of the airspace distal to the terminal bronchioles that is accompanied by destruction of the airspace wall. Sorry for that. So what about asthma? We know now asthma is a chronic inflammatory disorder of the airway associated with airway responsiveness that lead to recurrent episode of wheezing, shortness of breath, coughing, particularly at night. So usually it is associated with reversible airway obstruction, either spontaneously or with treatment. So mostly we are talking about the irreversible or refractory asthma that can lead to COPD. So the interrelation, there are some important points to understand the interrelationship more and more between chronic bronchitis, between emphysema and asthma. So patient with asthma whose airflow obstruction is completely reversible are not considered to have COPD. Patients with asthma whose airflow obstruction does not remit completely are considered to have COPD. So, on the other hand, chronic bronchitis and emphysema with airflow obstruction commonly occur together, and persons with chronic bronchitis, emphysema, or both are not considered to have COPD unless they have airflow obstruction. So what about the risk factor of COPD? As we know, we have many risk factors. The main risk factor that we are facing in our clinic is smoking, of course, family history, genetic, and other factors. All of this, we should address it in our clinic by taking a deep, detailed history from our patients. What about the complication on the other hand? So patient presenting with COPD, especially COPD exacerbation, patient is not responding to treatment, we need to think about other differential diagnoses like respiratory infection, pneumonia, heart problems, lung cancer, pulmonary hypertension, and as we know that chronic diseases can lead to depression in those patients with chronic pain or chronic diseases. So we need to screen for depression in those patients. These are some of the common risk factors for developing of lung cancer. So patient smoker more than 55 years with emphysema on CT scan and obesity, all of these patients are decrease in low body weight, all of those patients. So we need to think about lung cancer and we need to screen for lung cancer. So let's get this. So what about the clinical feature of COPD? So the three cardinal symptoms of COPD is dyspnea, chronic cough, sputum production, and the most commonly, or the most early symptom is exertional dyspnea. So sometimes we are mixing the exertional dyspnea between, is it a cardiac problem or it is COPD? So we need to screen both and we need to take it seriously with those patients. Less common symptoms include wheezing and chest tightness. Really, we're not seeing this much. Mostly we are seeing the exertional dyspnea and chronic cough. About 62% of patients with moderate to severe COPD report variability in symptoms over the course of the day, 2 weeks. So what about screening? Should we screen patients with COPD or not? So routine screening is not generally indicated for adults who have none of the features suggestive of COPD. On the other hand, waiting for patients to report symptoms may miss a large number of patients, and I believe this is our main problems in the clinic. So I believe we are missing or underdiagnosing many patients with COPD. So always I say it is a sharing management between primary healthcare and pulmonologists. So at least our patients who are suspected to have COPD, they deserve to be referred at least once for spirometry. Okay, so performance of spirometry by ordering. So in some family physician, they have the privilege to order spirometry directly and then refer or interpret the spirometry by themselves. I would prefer to at least refer the patient once for the first time for spirometry and to our colleague in Pulmo for more assessment or further assessment. And after that, we can follow the patient. So this is the most important first step. Initial chest X-ray could be helpful, but it's not recommended. High-resolution CT scan as a screening for lung cancer in a smoker over the year of 50 is recommended. Exclusion of COPD can lead to alternative diagnosis. This is another benefit from the screening sometimes, if we suspect other diagnosis. So what is our approach? Always we like to start our approach with thinking about differential diagnosis. So whenever we are face a patient with suspected COPD, we should think about whether it is asthma, as we said, there is interrelationship between asthma, COPD, chronic bronchitis, whether it's heart failure, especially if the patient is having like comorbid disease, diabetes, hypertension, obesity, and smoking. Is it TB? Is it bronchitis? Is it diffuse bronchitis? Or bronchitis, so we should think about all of these differential diagnoses. So what about the history? So the history is a cornerstone in family medicine and in primary care. So always, please take your time, at least spend the first 10 minutes taking detailed thorough history with your patient, starting with the chief complaint, which is mostly the chronic cough and shortness of breath. Then after that, go to the presenting illness, screening for the other involvement system, taking more detailed history about the cardiovascular, respiratory history. Of course, as we said, there is a family history sometimes. Ask about risk factor in detail. What is about the social history of the patient? All of these very important to be asked about. Of course, when we talk about social history, we need to know more about the smoking habits of our patients. Other important point here before going to the next slide is sleeping. Most of those patients, they suffer from sleeping, obstructive sleep apnea, or other sleeping disorder that affecting their quality. Of course, as we said, chronic diseases can lead to depression. So the last 2 or 3 points in our screening in family medicine, and I believe this is in all specialties, we need to do a psychological screening for our patient and finish and end our history by addressing the hidden agenda and summarizing the case for our patient. So capture, which is a tool that can be used in our clinic, which is COPD assessment in primary care to identify underdiagnosed respiratory diseases and exacerbation risk. So it is a useful, quick tool that can be done in the clinic within minutes with our patients. Moving to the physical examination, sometimes we are missing the examination because of the shortness of the time, consultation time, but I believe it's very important to do like a quick examination for a patient suspected with COPD. So chest examination vary with the severity of COPD. Early in the disease, examination may be normal or may show only prolonged expiration or wheezing on forced exhalation. So it sometimes could be subjective. As the severity of the airway obstruction increase, physical examination may reveal hyperinflation, decreased breath sound, wheezing, crackles at the lung bases. So here it's a feature of severe disease include increase in anterior posterior diameter of the chest. This is one of the, again, of the cardinal symptoms in physical examination. Tripod position, as we can see here, this is another feature in severe COPD patient. We can discuss it in detail. And other examination like use of accessory muscles, expiration through pursed lips, retraction of the lower interspace during inspiration, say nosing, neck vein distension. All of these are a simple physical sign that we should pay attention to it while we are examining our patients. Of course, yellow nail in smoker and clubbing, we shouldn't forget this important to physical size. What about lab? Is it indicated? There is no recommendation to do any lab or diagnostic set in COPD patient. Maybe B&B if you suspect heart failure. If you want to screen for other chronic diseases like doing like a renal function test, you want to check the glucose, the lipid, the thyroid, all of this can be checked as part of the general checkup for the patient. What about the alpha-1 antitrypsin deficiency? It's one of the risk factors. It is genetic. So there are some features in the history that can help us to decide whether to order it or not. So patient emphysema in young individual, we're talking about younger than 45 years, more or less, emphysema in non-smoker or minimal smoker, emphysema characterized by predominantly basal changes on the chest radiograph and family history of emphysema. All of this could be a criteria to test a patient for alpha-1 antitrypsin deficiency. Let's skip this, okay. So what about chest x-ray? So the main reason to obtain a chest radiograph when evaluating a patient with COPD is to exclude other diagnoses like lung cancer, pleural effusion, or heart failure, or even pneumonia. So plain chest radiograph have a poor sensitivity for detecting COPD. If you want to do like a simple chest x-ray, you will not get any benefit unless you are suspecting other diagnoses. What about CT on the other hand? It's not routinely recommended unless you are suspecting another diagnosis. Sometimes it could be helpful with certain patients who may be having some complication because of COPD. So it is performed when a change in symptom suggests like complication of COPD, an alternative diagnosis, lung cancer screening, a patient is being considered for medical lung volume reduction. So this is the main or the most important slide which summarizes the role of family physician. So we need a detailed history, we need a detailed examination, we need at least to confirm the diagnosis to do a spirometry. Diagnosing COPD is not by examination and history. You need to do, it's a must to do spirometry and imaging and lab if indicated. And always, I said at the beginning, it should be a shared management with our colleague in pulmonology. And this is, as we can see here, spirometry, just to diagnose COPD, we need the forced expiratory volume over the forced vital capacity to be less than 0.7, and this can confirm the diagnosis and airflow limitation, and by this way we can see that our patient is having COPD. Moving to maybe the staging parts of for our COPD patient, we'll not talk in detail because this will be covered in the next presentation. So there are more than one tool. Mostly the GOLD is the mostly tool that is used to classify the severity of our patient, and this is the second most important slide and the second most important rule in family medicine. So in GOLD, we are talking about the symptoms, we are talking about the airflow, airway limitations. So there are two main tools, okay, I will not go again in details. Merck and CAT, they are the two most widely used measures to assess the symptoms of COPD, and each one, as we can see, has a different grade. So in Merck, you have a grade from 0 to 4, depending on the history. So we need to ask a certain questions for our patient. Always, I prefer to keep these forms on my desktop or in my desk, so it will become easier for me to remind our patient, to remind ourselves to ask whenever the patient is available. So CAT, again, is another form that has 8 scores, and again, both of them will help us to assess the severity of COPD in our patients. And you can find like small card like this, combining both CAT and Merck together, so it will become easier and mostly and more practical in your clinic to use it with your patients. So moving to the airflow limitation or airway limitations. So it can be classified according to spirometry to 4 classes: GOLD 1, 2, 3, and 4, from mild to severely. And all of this will help us in deciding the management of our patient, as we can see here. So these are the widely used summary of how to classify and to decide the management of our COPD patient, but this is considered now a little bit old. As we can see here, the first step is using the spirometry to confirm the diagnosis. Okay, then moving after that to classify the airway limitation, and then after that we will use the Merck and CAT to classify the symptoms of our patient. So what is the updates in 2023? So they changed the ABCD severity group to ABE, which highlight the importance of the number and severity of exacerbation irrespective of the daily symptoms. And the mainstay of the initial treatment for symptomatic COPD should include combination of LABA and LAMA bronchodilators in a single inhaler. And for patients with features of concomitant asthma and eosinophil greater than or equal to 300, an ICIS LABA-LAMA combination inhaler is recommended. We'll talk about this in more detail with our colleague in the next lecture, inshallah. So these are this slide present the latest classification for COPD patient, and it becomes easier for us as a healthcare worker to classify our patient according to the Merck CAT, which is representing the symptoms of COPD, and by asking the patient how many exacerbations per year they have. And we have, on the other hand, the severity, airflow obstruction severity. On the other hand, by this way, we can classify our patient whether they are in the class A or B or E. Most of our patients we are seeing in our clinic, I believe they fall between the class B and E. So these are a summary of most of the treatment that we are using sometimes with our patient, of course, with a discussion with our colleague in pulmonology. So LABA, LAMA, ICIS, vaccines, other medications, maybe sometimes some of our patients, they need oxygen therapy. So all of this can be ordered by the pulmonology. So this slide, again, this is another practical slide that can be used in your clinic. So we can see here the group. So patient with A, so mostly they can use bronchodilator, mostly short-acting plus minus long-acting. Group B, we need to add more and more long-acting bronchodilator like LABA and LAMA. In the group E, especially with exacerbation and eosinophil more than 300, combination of LABA and ICIS could be considered with those patients. So I will skip this slide, but I will highlight the question. Are we still using LABA ICIS long-acting bronchodilator plus inhaled steroid alone, or we should move to the combination? This will be the point for discussion for today, inshallah. I will skip this, of course. This can be discussed in the next lecture. So our main rule as a family physician here is, number one, COPD management should be a shared management between primary care and pulmonology. For all COPD patients, we need to stress more and more about risk factors, especially smoking cessation. We need to pay more attention. We need to give more time for smoking cessation. Of course, we shouldn't forget the influenza and pneumococcal vaccination, and we need to discuss the physical activity, whether the patient can do physical activity or not. We need to emphasize more and more about regular follow-up and review and correction of inhaler technique. We should deal with COPD patient as we are dealing with diabetic and hypertensive patient. And finally, we need, of course, to insist about following with our colleague in pulmonology for reassessment and whether they need pulmonary rehabilitation or not. So final point here is a new article about bronchodilator in tobacco-exposed person with symptoms and preserved lung function. Usually we rush to label smokers directly with COPD. It's emphasized now and it's recommended now directly. We should go and do spirometry even for COPD for smokers to confirm whether they have COPD or not. And all of this very important because it will help us to decide about what are the suitable management for our patient. So take home message, prevention is number one, and this is the main rule of family medicine by tackling all the risk factors, especially smoking. Secondly, diagnosis and classification from the beginning and by early spirometry. And finally, shared management and early referral for our colleague in pulmonology. Thank you so much. This was my last slide. Thank you.
Thank you so much, Dr. Badr, for this extensive illustrated presentation that shed light on the role of family physician and the primary care physician in the management of COPD. And for the sake of the time, I would like to welcome our next guest speaker, Dr. Mohammed Omar Shamma, who is a consultant intensivist in Ministry of Health, East Jeddah Hospital. Dr. Shamma had a fellowship training in US, and he is certified by the American Board of Internal Medicine and Internal Medicine, pulmonary medicine, and critical care medicine. He has been working here in Jeddah since 2008 as a pulmonologist and intensivist and critical care intensivist in the government and even the private sector. We had the privilege of having Dr. Shamma with us in IMC since we established the ICU unit, and it was running, by the grace of Allah, and then by his support to be one of the unique and brands in care of intensive care unit in Jeddah. He has an American Board of Internal Medicine and certified in critical care medicine and pulmonary disease. So Dr. Shamma will speak about the COPD current evidence for diagnosis and management. So thank you, Dr. Shamma. Looking forward to hear from you.
بسم الله الرحمن الرحيم. السلام عليكم. Good evening, everyone. Seems like Dr. Ashraf, Amir, and the organizing committee liked my presentation last year, so they invited me again. So thank you so much. I'm deeply honored for this, and thank you very much. When I was invited, I was hoping to use the same presentation from last year with few additions, but focusing on the new update this year, turns out I had to start over because there's a lot of changes. Most of the recommendations for COPD management is based on GOLD recommendation, Global Initiative for Obstructive Lung Disease. And they publish a report every year with just minor changes usually. But every few years, there is a major changes in the recommendations based on the most recent available research. And this year, 2023, was one of those years where there was a major overhaul and a lot of new recommendations, and I will focus on that. So the recommendations, first of all, focus on the pathophysiology and the definition of COPD. And it starts based on recent recognition that COPD is not always a disease of smoking. Smoking was and still is one of the major risk factors for smoking, but it's recognized for COPD. But it's recognized that a lot of cases of COPD happen in non-smokers, especially in female and younger age. So traditionally, the typical COPD patient was like the one on the left side, elderly smoker. But it's now recognized that COPD can happen in female. Actually, it depends on your patient population, with almost equal prevalence in males and females. And a lot of factors other than smoking contribute to the etiology of smoking, of COPD. Some of these are genetic factors and have to do with the lung development, and some have to do with exposure to things other than smoking. So on the left side of the slide are some of the risk factors for the development of COPD. Now the talk is about getomics as a science or fields or etiology of COPD. Just like genomics and proteomics, we talk about getomics with abbreviation GET for the pathophysiology of COPD. The G is the genetic predisposition, E is for environment or exposure, exposome, and T is time. So complex relationship between these three parts over time lead to the development of COPD. And genetic factors lead to poor lung development. Not only many factors can lead to poor lung development, which can lead to COPD later in life. Some of them are genetic factors, some of them have to do with maternal smoking, poor lung development because of repeated childhood infections, because of malnutrition, and then the exposures. Again, so smoking is a major risk factors, but there's other pollutants, indoor pollution and occupational exposure, exposure to biomass fuels used in like wood, used in heating or cooking, especially in poor areas. And then infections also, like tuberculosis, HIV are recognized as risk factors for the development of COPD. Asthma, especially poorly controlled chronic asthma, can lead to COPD. Asthma and COPD are different diseases, but there is this complex relationship between them, and it's definitely recognized that poorly controlled asthma can lead to COPD. So the interrelationship between all these factors lead to a stage of pre-COPD, which is in the middle of the slide, which is recognized by either development of symptoms, but no typical manifestations of COPD required for definition, which is the spirometry finding of obstruction. Obstruction measured by spirometry, defined by FEV1 to FVC ratio of 70% or less, is a requirement to establish a diagnosis of COPD. But other than that, defining patients at earlier stage is what's now talked about as a stage that can be intervened at to prevent the development of full-blown COPD. But the recommendations are still not clear. Practically, the obvious, which is avoiding smoking and avoiding the risk factors, but how to treat such patients is still not clear, and there is no specific recommendations. But that's why the report emphasizes that we can catch these patients early and encourages research in this area. The pre-COPD, for example, finding or incidental findings of emphysema on CT scan without symptoms and without the typical spirometry findings, or spirometry slightly impaired but without showing the typical obstructive pattern called PRISM, preserved ratio impaired spirometry. These patients fall under the umbrella of pre-COPD. COPD, again, at the right side of the slide, defined typically by the presence of airway obstruction in spirometry in a patient with symptoms and risk factors. Looking at things from another angle, this is the trajectory of FEV1 in health and disease. Again, it's recognized now that the issue is not only in the decline of the lung function, but it's recognized as many patients as the ones with steep decline actually have a problem in the lung development. Physiologically, in the curve in black, there is a period of increasing lung volumes and maturity between birth and 18 years of age in females and 20 to 25 years of age in males. This is the physiological maturity and development, and then there is a plateau phase until the late 30s, and then there is a physiological decline with aging. It has been known that smoking accelerates this decline, and the presence of COPD accelerates this decline in various degrees. Some patients have more rapid decline than others. But even the plateau phase and the maturity phase is also impaired, and this is recognized now as a major risk factor for COPD. And again, the focus should be on prevention of the factors that can lead to development of COPD in such patients. So what's new in COPD? Again, this is, even the definition has changed. I highlighted the changes in boldface. So it's recognized now as a heterogeneous condition, not a single diagnosis, not a disease. They changed the terminology from a disease to lung condition, recognizing that these many factors, the poor lung maturation, the increased decline caused by a variety of risk factors can lead to the same thing, which is the symptoms plus the obstructive pattern. There is a nice article which these recommendations are based on by Dr. Celli, Dr. Bartolome Celli, one of the pioneers in COPD, and talked about definition and nomenclature. And he starts by describing the unfortunate current status of COPD, that it's still a common disease despite being preventable, but very prevalent, and one of the leading causes of death worldwide. And even though there is improvement in the management and decrease in mortality of COPD patients, but it has not caught up to other fields in medicine. It was not as good as the coronary artery disease or stroke. And he recommends or encourages research and to improve our understanding of the disease and to improve its prevention and catching patients earlier to achieve this. He likens it also to diabetes mellitus, where there is different pathways or different pathophysiologies, type 1, type 2, impaired insulin secretions, insulin resistance, all leading to the same thing, which is hyperglycemia and impaired glucose control. And the same is proposed in COPD, that many factors lead to the same thing, which is the obstructive pattern and the presence of symptoms. So it's now called a condition rather than a disease, heterogeneous condition. Different etiotypes are described. Again, many things can lead to the development of COPD. Some of them are genetically determined. Most of them are not, it's not a specific gene, but rarely alpha-1 antitrypsin is recognized as a cause. And this is one of the rare things that have a specific treatment, which is the replacement therapy for alpha-1 antitrypsin in patients with upper lobe emphysema and alpha-1 antitrypsin deficiency. COPD due to abnormal lung development, either due to prematurity or low birth weight or repeated childhood infections or malnutrition. The environmental COPD, most commonly cigarette smoking, but it's not only that, exposure to indoor and outdoor pollutants. And then occupational exposures also. COPD due to infections is another category. And COPD and asthma, which again, there is this complex interrelationship, but can be summarized as poorly controlled asthma can lead to COPD later in life. And they're the COPD of unknown cause. Again, this highlights that not all cigarette smoking is definitely a major risk factor for COPD, but that's not the only risk factor. And as much as there is a variety in the etiologies, etiotypes, there is also variety in the phenotypes. And this has been recognized for some time, that some patients present more of the chronic bronchitis symptoms, which is a lot of mucus, sputum production. Some have more, traditionally described as blue bloater versus pink puffers. Some have rapid decline in the lung function. Some have a lot of comorbidities, mainly coronary artery disease. In fact, heart disease is the major cause of mortality in COPD. Some has physical frailty, typically being thin and losing muscle mass. And there's the emotional considerations, depression, as Dr. Badr mentioned. And so these comorbidities have long been known that COPD is a multi-system disease. And there's many hypotheses or theories on why this happened. But the most likely is that there is a spillover. It's called the spillover hypothesis, where there is a spillover, that the same inflammatory mechanisms leading to COPD in the lungs spill over to many organ systems and cause chronic inflammation. And this chronic inflammation causes things varying from coronary artery disease to muscle wasting, depression, sleep apnea, cachexia, all these things. And this should be considered, of course, in the management of COPD, the comorbidities. Actually, that's, I always like to speak in front of family physicians, and because I feel that they are best, the patient with COPD is best served by the holistic care, the holistic management provided by family physicians, because not focusing only on the respiratory system, but keep paying attention to all these considerations. So COPD is suspected in patients with the typical symptoms of dyspnea and cough, especially productive cough, and especially in the presence of risk factors. But spirometry is definitely needed to establish the diagnosis of COPD. So what's spirometry? How does it diagnose COPD? What's FEV1? What's FVC? Basically, to simplify it, it's a forced expiratory maneuver where the patient is typically coached. Typically, people need to be coached and explain to them the maneuver. And after a maximum inhalation, the patient takes a deep breath, maximum inhalation, and then maximum exhalation, usually over 5-6 seconds, which gives the FVC, the forced vital capacity. So we measure the expiratory volume in the first second, and we measure the ratio of that to the total amount exhaled. The ratio, being an obstructive disease, will decrease, especially in the first second. So the ratio will decrease and will become less than 0.7 or less than 70% in patients with obstruction. And this is required to establish a diagnosis of COPD, this obstructive pattern, FEV1 to FVC ratio of less than 0.7, less than 70%. And again, this is a mandatory or essential to establish the diagnosis. In a patient with symptoms, but they don't have this, they fall under different categories. And then based on the number itself, how much percentage of predicted value, we grade COPD into different grades. But grades are useful in prognosis, but as you will see in the next few slides, it doesn't really matter much for treatment. The goals of treatment of COPD are two things: the immediate, the obvious, and the long-term, the hidden, not obvious. Obvious, the patient wants to have better quality of life, less symptoms, more exercise tolerance. But as important is prevention of complications, improving survival and decreasing mortality, and decreasing exacerbations. So these are the treatment goals of patients with stable COPD. Stable meaning not in exacerbation stage. So another major change was the simplifying the groups. It used to be 4 groups, A, B, C, D. Now it's A, B, and E. There is 2 axes. Again, there is in the middle, there is the assessment of airflow obstruction. It is important for prognosis, but the treatment decisions are based on the right side of the slide, which is all by history, asking the patient about how many exacerbations in the past year and how bad the symptoms are, using any of the questionnaires that Dr. Badr mentioned, the MMRC or CAT. But basically, most of the patients will fall under either B or E. Either they have a lot of symptoms or a lot of exacerbations. That's why they come to the clinic. We rarely have patients in group A, which they have only mild symptoms. So A and B are, A is very occasional symptoms or low symptoms, B, more symptoms, E, more exacerbations regardless of the symptoms, at least 1 exacerbation leading to hospitalization, or 2 or more mild to moderate exacerbations. So the treatment of such patients, most of the patients will, and just to emphasize, this is the initial pharmacological treatment. This is treatment with the first encounter with the patient. What's new in 2023? It's 3 groups rather than 4, and LABA inhaled steroid is not recommended as a first-line management of patients with COPD. Most of the patients are recommended to be started on LABA plus LAMA. So what are these LABA, LAMA abbreviations? LABA is the long-acting form of beta agonists. Albuterol is the short-acting form, albuterol, Ventolin, and the long-acting forms are LABA. So usually they end in erol suffix, like vilanterol, salmeterol, formoterol. So these are the LABA. They work by bronchodilation. Another way of bronchodilation is the anticholinergic LAMA, which are the long-acting forms of ipratropium, Atrovent, the long-acting forms, or glycopyrrolate. So the name is either tiotropium in the opium with this suffix, or omeclidinium. There's also a new generation that has omeclidinium. And ICS is inhaled corticosteroids, budesonide or mometazone, fluticasone. So for the pharmacotherapy of COPD, we want the maximum bronchodilation. And currently the maximum bronchodilation is achieved by a mixture or combination of these 2 pathways, LABA plus LAMA. And this is what's recommended for most of the patients. It's been found also that it decreases the exacerbations. Now, more effective for decreasing exacerbation is adding inhaled steroids, and we'll touch on that also in the next slide. Most of the patients should be started on this combination of LABA plus LAMA, except the ones with very mild symptoms, which can be, any bronchodilator can be used. The recommendation does not specify, preferably long-acting bronchodilator also, but not specifically the combination. And again, I repeat, this is the initial pharmacological treatment. If there's no improvement in the next visit, there is another pathway, and usually they will be upgraded to an additional inhaler. LABA plus inhaled steroid, like the typical treatment of asthma, is not recommended as a first line in COPD anymore. The first line is LABA plus LAMA, and in certain patients with frequent exacerbation, the addition of steroid is indicated. We talk about steroid stewardship, which means we would like not to give steroids unnecessarily. So there's in deciding whether or not to add inhaled steroids, we can use these considerations. Steroids are known to decrease exacerbations, but they are also known to increase the risk of pneumonia. So if the patient is known to have pneumonia in the past or mycobacterial infection, this speaks against using steroids. If they have frequent exacerbations, 2 or more moderate exacerbation or only hospitalization, this strongly favors the use of steroids. And we talk about using eosinophil level to guide the decision to use inhaled steroid. Steroids are recommended, as in the previous slide, if the blood eosinophil level is more than 300. About the eosinophil count, few considerations can be emphasized. First of all these numbers are within the normal range. So don't expect the lab result to flag or to show high. It's still all in the normal range. Second thing is, depending on your lab, the results may be in fewer numbers because they're using the nanoliter per 10 to the power of 9. So the highest will be 0.5 rather than 400. We have to 500. So we have to multiply by 1,000 to get the conversion to 300. So 300 means 0.3. As in the table, this is it's showing the eosinophil count from 0.04, that's 40, to 400. And again, the maximum here is 400. So if it's below 100, that speaks against using eosinophils. In between 100 and 300, borderline, and above 300, steroids are recommended. Smoking remains a major cause of morbidity, and unfortunately, a lot of COPD patients continue to smoke, so smoking cessation is essential. What I just talked about was all the inhaler therapy and pharmacotherapy. but as important, if not more important, the non-pharmacological interventions for the COPD patient. And one of the major things is avoiding the respiratory irritants or occupational exposures, and or of course smoking. Smoking cessation is not easy, and it's easier said than done, and it takes a lot of effort from the patient side. From the physician, we have to spend at least some time with the patient, asking and encouraging. It's not only a matter of just prescribing a medication, but it takes persistence and follow-up. And these are all supported by evidence-based and shown that improve smoking quit ratio. And it's also, smoking cessation is one of the few interventions that have been shown to improve outcomes, even the mortality. Well, very few interventions have been shown to decrease mortality in COPD, and one of them is smoking cessation. E-cigarettes are not totally safe, but likely they are better than cigarette smoking, but they are not recommended as a way to quit smoking. Nobody found this funny? Okay. Vaccinations are important. COVID vaccine, influenza, pneumococcal. Pertussis vaccine is important because it was found that a lot of the exacerbations are caused by undiagnosed pertussis, whooping cough. Shingles, zoster vaccine is recommended, especially after 50 years of age. It's recommended for everybody anyway after that age, but below 50 can be offered also because COPD patients have higher risk of acquiring the infection and having complications. So I hope I was able to highlight some of these points, and I would be glad to talk about them further in the question and answer session. And thank you.
Thank you so much, Dr. Omar, for this nice presentation. And now we are going to have another session, which is very unique. In fact, we have made a decision by the scientific committee to have the participation of our residents for the first time. IMC is well known to have more than 12 residency programs plus 2 fellowships, and we have a good number of talented residents. So we thought that their contribution is very important for us. So that's why I would like to introduce today Dr. Dalia Flimban. She was graduated from Al-Qura University as a medical student, and she was a member of the Medical Student Club in Al-Qura University, and she's currently in the Family Medicine Residency Program and the Joint Program of Family Medicine and in the International Medical Center. And since she was graduated, she was fully engaged in a lot of scientific events and even research. And today she's going to highlight a real-world practical issue case. So there will be a case study in COPD in the practice of primary care. So on your behalf, I would like to welcome Dr. Dalia, and looking forward to hear from you, Dr. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everyone, and thank you for coming today. Before I start, I would like to thank Dr. Ashraf for giving me this chance to be honored to present here today. So, we have a case of a 56-year-old man with a history of smoking, present to the primary care physician with shortness of breath and cough for several days. His symptoms began 3 days ago with rhinorrhea. So he reports a chronic morning cough with production of white sputum, which has increased over the past 2 days. He denies hemoptysis, chills, or weight loss, and has not received any relief from over-the-counter cough preparations. Going further to the history and asking about smoking, he said he smoked 1 to 2 packs of cigarettes per day for 40 years. So this is a hint that he is a heavy smoker. And also he had similar episode as well each winter for the past 4 years. So what is the most likely cause of his symptoms? Obviously, it's chronic obstructive pulmonary disease. We excluded asthma because it's less likely. Actually, all of the options can be a differential diagnosis, but according to this case, we thought asthma is less likely because the patient have risk factor of smoking, and as well as he have productive cough, which can go more with COPD. As well as congestive heart failure, as doctors mentioned before, it's important really to have a good history to exclude if there is any cardiac risk symptoms. And finally, tuberculosis, we excluded that because, as we mentioned, the patient doesn't have fever or chills or any constitutional symptoms. So, regarding COPD, as the doctor mentioned, it's characterized by chronic respiratory symptoms and airflow limitation that often progressive and not fully reversible. Suspected patient with a history of smoking, occupational and environmental factors, as well as personal or family history of chronic lung disease. So usually our patient can present with many symptoms, but these are the most common symptoms we can see at the primary care: cough, production of sputum, shortness of breath, and exposure of risk factors, and most importantly, smoking. Also, the patient can present with fatigue, can present also with headache, secondary to hypercapnia. And in some severe cases, patient also can present with chest tightness, exertion, weight loss, and anorexia. And on examination, patient may present with hypoxia, and as well because the patient can be in exertion, can present also with the use of accessory muscles, distant heart sound, lower limb edema, clubbing, cyanosis, and also can present with hepatomegaly, secondary to cor pulmonale. Yes, and this is for the signs symptoms. So for risk factor, as we all know, smoking is really important to consider in the history. Also advanced age, male sex, but as Dr. Shamma mentioned, also female can have it. Genetic factors, lung growth and development, white ancestry and exposure to air pollutions. Occupational exposure and low socioeconomic status, and some studies showed that rheumatoid arthritis can be related. What vaccinations are recommended for patients with COPD? As Dr. Shamma mentioned, annual influenza vaccine is really important. Also, one-time pneumococcal vaccine, but he also told us again, and actually that was a new information for me, to never forget pertussis vaccine, and of course, as we all know, zoster vaccine. So what is the screening recommendation of COPD in asymptomatic adults? So according to the United States Preventive Task Force, it is not recommended to screen adults who are asymptomatic. And the grade of evidence is D. So to wrap it up, chronic obstructive pulmonary disease can be characterized by persistent and progressive airflow obstructions, and subtypes are emphysema and chronic bronchitis, clinical presentation, respiratory symptoms, cough, shortness of breath, diagnosis by spirometry mainly, and treatment, as Dr. Shamma mentioned also, long-acting beta agonist, muscarinic agonist, and inhaled corticosteroid can play a role. A risk factor, never forget asking about smoking, and occupational and environmental factors. These were my references, and thank you.
Thank you so much, Dr. Adalia. Very informative. And now we'll go for our guest speaker, Dr. Sultan Ganesh. He's the Director of Sleep Medicine Center in King Abdulaziz Medical City in Jeddah. And he's a Joint Associate Professor of Medicine and Pulmonology, College of Medicine, King Saud bin Abdulaziz University. And he's a consultant pulmonology and sleep medicine in King Abdulaziz Medical City. And he has a membership of the national and international societies in the field of the chest, sleep, and internal medicine. He's going to shed light on the early optimizations of the COPD. So thank you so much for being with us here, Dr. Sultan. Looking forward to hear from you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Ashraf, for this nice introduction, and thank you all for being in this scientific activities late at this time of the night. And it's my pleasure to be with you in this scientific activities as well. So my lecture is going to be concentrated on the triple therapy, mainly in COPD. So this is my disclosure. And this is the agenda for this lectures. I will highlight some changes in the GOLD Guidelines 2023. We'll talk about the molecules in the triple therapy, and we will differentiate between the single inhaler triple therapy and the multiple inhaler triple therapy. And we'll see if there is any difference between these triple therapies in different companies, and how can we differentiate between the devices and how these devices can help our patient to improve their conditions, and then we'll end up with some summary. So I have a few slides. Actually, this is a replication of what has been done or talked in the previous lectures. And because the GOLD guidelines changed the condition or changed the definition of the COPD, we have to highlight about it that the COPD is heterogeneous conditions and characterized by many specific symptoms like cough, shortness of breath, and wheezy chest. And this is because of abnormality in the alveoli and the airway itself. This is again already mentioned in the previous lectures, and we highlighted on the classification or the assessment of the COPD based on the symptoms and the exacerbations and hospitalization as well. Previously, the COPD was classified as ABCD, now it's classified as ABE. Why do we need this classification? Because based on this classification, we can phenotyping our patient and starting or initiate the best treatment for our patient. So based on this classification, we can start the bronchodilator, and we can combine the bronchodilator based on the phenotype or the group of the COPD. We will concentrate on the group E. In the group E, we started to have the triple therapy in a specific type of the patient. Those patients with have a lot of exacerbation or frequent exacerbation in the last year, and the eosinophil or eosinophil more than 300. For the first time in these guidelines, there is a benefit of the pharmaceutical medications because of decreasing mortality, or there is a reduction in the mortality. And this is the first study called IMPACT study that comparing the triple therapy to the double therapy for the COPD, and it showed that the triple therapy can reduce the mortality by 42%, as you see here in this figure. And this is what has been highlighted in the studies. For the first time, pharmacotherapy, as you see here, triple therapy for LABA, LAMA, and ICS, based on the two studies, IMPACT and ETHOS studies, reducing the mortality in those patients who are symptomatic and need the treatment for triple therapy. So what are the triple therapy that we have in our market? So we have the fluticasone fumarate, umeclidinium, glycerol as a single inhaler triple therapy. Also we have budesonide, formoterol, and glycopyrronium as a single inhaler, and we have multiple inhaler triple therapy that has been used for more than years, like ICS LABA with the LAMA as single inhalers. So if we are talking about the triple therapy that include fluticasone fumarate, umeclidinium, and flenterol, it contains three components: ICS, LABA, and LAMA. And as everybody knows that we need this medication in our COPD patients who needs this medication because of high eosinophil and they have frequent exacerbations, because ICS reducing inflammations, LABA promote more bronchodilator, and LAMA inhibit the bronchoconstriction, and these components works for 24 hours. So Are all ICS are the same? Because still we have other triple therapy. We can give the patient multiple inhaler or the other modalities of a single inhalers, but we have to differentiate the type of the ICS. As you see here, there is a difference in the pharmacokinetic and pharmacodynamic of these ICS. And as you see in the first diagram in the left side, in your left side, there is high receptor binding affinity for fluticasone fumarate comparing to the other type of ICS, and this is lead to low therapeutic dose. And also there is low absolute bioavailability of this medication that lead to the decrease of the systemic effect of these medications on those patients. What about the LAPA? As you see here, as highlighted by the blue color, for filantrol, comparing to the other medication, has a good onset of actions, and there is high selective or high specificity for the beta-2 receptor comparing to the other molecules. What about the other component, LAMA? We have the titrobium in our market. Also, we have the other medications, umeclidinium, as a part of the medication in the triple therapy. As you see here in this figure, there is improvement in the lung function there is a difference between the titrobium and umeclidinium by 62% in the FEV1 on the trough of FEV1 that lasts for more than 24 hours. What about the difference between a single and the multiple inhalers? So this is the most important things, because now we have the single inhaler. We used to use a triple inhaler as a multiple inhaler triple therapy. This is Interbed clinical studies, is a randomized open label study for 24 weeks, multi-center, comparing the single inhalers of fluticasone, umeclidinium, and vilanterol once daily versus other non-ellipta twice daily inhalers as a real life practice. And this medication was used in those patients who are aging more than 40, diagnosed with the symptomatic COPD, and has frequent exacerbation as a moderate or severe exacerbations. As you see here, using of this single inhaler compared to the multiple inhaler, there is improvement in the CAT as the health status of the patients by 31%. Also, there is improvement in the lung functions if we comparing two modalities. The other things, as a real life, the most important things for our patient is the adherence. So this is a study done in UK and showing how is the adherence in those patients if those patients using a single inhaler or multiple inhalers. By logic, using single inhalers is associated with the more adherence compared to the multiple inhalers, as you see also in this study, in 6 months, 12 months, and 18 months. Another study also about the adherence in the US and showing there is single inhaler has those patients with the single inhaler are more adherent to the treatment comparing to the multiple inhaler. So what about the triple therapy? Now we have multiple triple therapy. Are all the triple therapy are the same? Unfortunately, we don't have head-to-head trial to compare what have been used in this triple therapy. And to make indirect comparison between these triple inhaler, we can use what is called network meta-analysis. And by this network meta-analysis, we can have some information about this medication and the comparison between these two medications. In this systemic literature review, in this network analysis, they included randomized control trial that have been studied those patients more than 8 weeks, and they compared the single inhaler with the triple inhalers as well. And based on this study, or based on this network analysis, it was found that based on all study, all of the comparable, based on this study, the triple therapy ICS that include fluticasone fumarate, umeclidinium, and vilanterol are more effective comparing to the other medication. Okay, so we cannot take it as a solid evidence, but we can take it as indirect evidence to compare between those medications as well. The other things regarding to the severe exacerbations in more than 24 weeks, for those studies that involve more than 24 weeks, also this is favoring the medications with the triple therapy, umeclidinium, fluticasone furoate, and fenterol. What about the trough FEV1? Also, as you see here, there is also favoring the result favoring these triple medication comparing to the other triple medication and other double medication or dual medications. So, as you see here, based on this study or based on this network, we can say that there is additional lung function improvement if we use the triple therapy of fluticasone, umeclidinium, fenterol, comparing to the other single inhaler therapy in 12 weeks and 24 weeks. Also, regarding to the exacerbation, if we compare this with the other single therapy, also there is a favoring of these medications as medication that can decrease the exacerbation in those patients. So how can we differentiate between devices? This is the second most important for our patient. As everybody knows that sometimes we're facing some patients that they don't like this device because there is specific problem with this device. This is why sometimes we change the medication to another device because this is the patient's preference, okay? But what about if we have these devices based on the study, what is the best for the patient? This is a study showing or comparing different type of devices. Devices included ellipta, turbohaler, discus, and handyhaler. And as you see, the critical error is less when we are using the ellipta comparing to the other type of devices. What about the patient preference? Also, if we're comparing the ellipta comparing to the other devices, our patient or the patients preferred the ellipta comparing to the other devices as well. What about the minute of training? Because when we are facing the patient, usually we send our patient to the health educator to educate them how to use the inhalers and how they continue or maintaining the treatment or be compliant to the treatment. And the minute of training time for those patients is less with the ellipta comparing to the other medication as well. So, in summary, or our home take message that all triple therapy are not same. We need a triple therapy in specific type of patient or severe patient. Those are symptomatic with the high eosinophil and or frequent exacerbation in the last year. Also, there is a difference between the triple therapy in terms of the pharmacokinetic and pharmacodynamic, and this is very important for our patient to continue on the treatment as well. As you see, single inhaler triple therapy, including fluticasone, furoate, umeclidinium, and fenterol provides superior benefit, health benefit, and better adherence to our patient compared to the multiple inhaler triple therapy. And elliptic device has low critical error rate, higher patient preference, and lesser time to teach correct use. So this is for the safety information. You can use this to contact for any concern. And thank you.
Thank you so much, Dr. Sultan. Now it's a time for the Q&A session. So I would like to invite all the speakers to be on the stage here to receive the questions. And as we go, we will start by giving the privilege to the physically attending physicians, because we have more than 1,000 attendees now with us on virtually. So any question from the audience here? Start Hamid. Anyone? All right. There is a question, I don't know who is going to answer it. In fact, how lung growth and development can be the risk factor for the COPD. Is it during the development of the lung, or as we know, at certain stage of life, we are losing certain lung capacity? Is what is meant by?
All these are factors starting at birth, actually starting from maternal smoking, which impairs the lung development in utero, in the uterus.
Okay.
So it starts as early as that until the period of the expected maturity, around 18 years of age in females and around 20 to 25 years of age in males. So anything during this period, again, from maternal smoking to prematurity, being born early, low birth weight, malnutrition during early infancy and early childhood, repeated childhood infections, all these are known and proven to affect lung growth. That has been known from before, but now it's recognized that it's a real risk factor for COPD and as important as the exposure history later in life.
Okay, so we have to keep it as a potential risk factor for those groups of populations, especially when they are getting into the stage of smoking on top of this. So this will be a highly suspicious and high focused patients of high risk for COPD.
Absolutely,
Yes.
and that is, if I might add, that adds to the importance of avoiding smoking at any stage of life to any person. We talk about primary prevention, secondary prevention, tertiary prevention with smoking avoidance. So primary prevention is avoiding the smoking of the mother so that it will not lead to poor maturity in her child, which is the primary prevention of this poor lung maturity. And secondary prevention is for the person not to smoke or to prevent COPD. And tertiary prevention for the patient with COPD to prevent the exacerbations and to prevent the worsening of lung function.
Okay, thank you. Spirometry was mentioned by Dr. Omar and Dr. Badr. The question is there a role of screening spirometry in the community?
Should I take that?
Okay.
No, the current called recommendations actually talk specifically about this and does not recommend screening healthy individuals or screening the community at large. It recommends screening people either with risk factors, obvious risk factors such as current or being ex-smoker, or symptoms. And it recommends this for case definition, not for diagnosis. So to define these cases and to catch them early. But it's not recommended for the community at large or for asymptomatic individuals.
Okay, thank you. Dr. Badr, you have mentioned elegantly the approach of primary care physician to COPD. To what capacity the family physician can handle COPD and when to refer? This is the point which has not mentioned very clearly. If you just...
Thank you, Dr. Ashraf. As I mentioned, I believe, and Dr. Sultan and Dr. Muhammad, they mentioned that our role is comprehensive, it's holistic. So we are taking the patient, we are suspecting the case, if whether the patient is having COPD or not. So I believe the first step is take detailed history, covering all the parts, especially the social history, starting the counseling about all the risk factors, discovering this risk factor, document this, and the area referral for spirometry. And I believe that we are underdiagnosing and sometimes missing cases because we are not referring, and maybe sometimes we are just overcoming this by just blindly prescribing the inhalers for our patient once they are improved. So they will not come to us, okay, or we will assume that they are just, improved, their COPD or exacerbation improved. I believe that taking deep history, having documented this very well, referring early referral for our colleague in Pulmo, and then after that, the continuous periodic checkup and dealing with those type of patients as if we are dealing with diabetes is our main role. We can remind our patient about the vaccination. We can decide with the patient whether the patient is progressing or the patient is controlled. Now we have the knowledge to reclassify the severity of our patient, whether he is in class E or C or E or B or A, and then after that we can at least refer the patient if we suspect that the patient need like pulmonary rehabilitation or oxygen therapy. As a continuation for the point from Dr. Muhammad, sometimes elderly patient, chronic smoking for 30 years, more or less, they will be disappointed to quit smoking. So why should I quit? Because I lost already my lung function. No, still, according to the evidence, there is a hope, and we can preserve some of the lung function, and we can prevent, of course, deterioration of lung function, especially if he is COPD patient.
Excellent. Dr. Sultan, you mentioned clearly and elegantly that not all the triple therapies are the same. What is your guidance for the family physician to choose among the different varieties of medication that we usually encounter, LABA, LAMA, ICS? This kind of combination, what would be the criteria to choose among the different varieties that we have?
Okay, still we don't have a direct head-to-head trial between these triple therapy that has been available till now. When we are talking which of which is very difficult sometimes, but we have to have in our mind that we have to share with our patients which is the best for the patient, because some patients can use some devices and prefer some devices over the others. This is the first thing. Second thing, regarding the patients, does the patient need this therapy or not? Okay, because there is a specific type of patient with the COPD, like those patients who are symptomatic with the high eosinophil count or has more frequent exacerbation in the last year. Those patients are candidate to be on the triple therapy. But to choose which of which, there is indirect evidence, but we cannot take it as a solid evidence to apply to our patient for everyone in our patient. So this is, we have to make like a discussion with the patient, and we have this medication and this medication. This is the available evidence so far. So the patient can share in taking the decision of the using the medications.
Okay, excellent. Fadal.
A question for Dr. Sultan. I don't know if you are considering, Dr. Sultan, is it practical or not to consider the deposition or the particle size in between, you know, the powder and the inhaler one? This is one. How do you, is it recommended to at least to measure the flow, expiration flow of the patient? Is it 30 or above or below 30? So elderly patient, maybe they don't have the ability to inhale. So maybe these are factors, some factors that could affect, you know, the selection of the inhalers.
This is right, but if we are talking about these triple medications, all of them are applicable to have a flow rate less than 30 or 30 to 40, and this is what has been in our COPD patient. Even during the exacerbation there, they are able to do inhalation as a flow rate of 30 to 40. So they can use all of these medications. But there is some specific type of the patient, they said that I don't like, for example, MDI, or I don't like turbo inhaler, because there is a difference in the devices itself. So we'll take this encounter with them sufficient, and based on that we can prescribe the patients.
Okay, there is a comment. Insurance companies, they cover all the treatment of COPD, but they are not covering smoking cessation program. So your comments, I'll just leave it for you to tell me. Dr. Badr.
Because unfortunately, until now, we are concentrating on disease management and disease prevention.
Yeah.
Yeah, this is obvious, and unfortunately, you have patients, and it's easy, alhamdulillah, the quit rate. I can talk about our clinic in IMC, in smoking cessation clinic. We reached to 80% and more than that, alhamdulillah. The response is very high. The main obstacle is the medication. So most of the medications is not covered, at least the patch is not covered. Patients are willing to be covered or to use the medication, but still they are not covered. But they are covered for the inhaler. So if we are prescribing inhaler, it will be approved for them or approved. But on the other hand, we are talking about patches, Wilvitrine or Papropion, previously Champix, all of this is not approved mostly. Thanks for MOH. It was provided by MOH, but still we need to emphasize more on that.
Okay, thank you. So, yeah, Dr. Abdulaziz, تفضل. In fact, we are privileged here today to have Dr. Abdulaziz Twain with us. It's an honor, in fact, to have you with us, Dr. Abdulaziz.
Thank you very much. I'm a pediatric endocrinologist, but first I would like to thank you for encouraging our residents and our fellows to present in these meetings, which is very, very nice to see Dr. Aflimban here. And that's why I want the question to you, Dr. Aflimban. The case you presented is very common problem, you know. Differential diagnosis, you put many things, chronic asthma, you put chronic obstructive pulmonary disease, you put also tuberculosis, but you didn't mention anything about lung cancer. This is a patient who is a chronic smoker, heavy smoker, present with this here. Why I'm mentioning this here? Because I know that there is some cases can be missed and wrongly treated as not cancer, and maybe especially using steroids for a long time. And that make the condition better initially, so the patient feel great, but later on, of course, it might mask an early lung cancer. Thank you.
Thank you so much, Doctor, for your comment. Actually, the list of differentials are longer than what I presented, but the case I presented, actually, it was like an MCQ, like how you would answer and what would you choose for an answer and how to exclude the others. But the list of differentials, of course, as you mentioned, is really important to mention lung cancer. So thank you so much for that.
Yeah, that's why we have to look into the profile of the patient and to make a risk calculations and to put the differential diagnosis in priority based on the facts that we are collecting. So this is a clinical expertise, to look into this. Yes.
And, Alhamdulillah, and since 2018, we started like a screening program in IMC. So we introduced for the first time in 2018 the low-dose CT scan,
Yes.
which is according to the Preventive Task Force. Okay, it's one of the modality for screening for lung cancer, apart from being a COPD patient. We discover many cases with the duals, incidentally, like with emphysema, sometimes incidentally with thyroid cancer. So I believe it's so helpful, it's available, but we need just to start to do it with our patient according to the guideline.
Yeah, thank you. Question, Dr. Muhammad?
Thank you very much. I think tonight I'm going to extend a little bit of my imagination. We are restricted in our vision. I think we need to inspire something about from the 2013 vision. How? Because I'm orthopedic consultant. Regarding the cases, yes, this is a case for total knee replacement. If we consider the other comorbidities like heart failure, for instance, we can get as well COPD, that when I'm going aggressive, changing everything, but the patient won't get the benefit for the long run. I think we need, that's why I suggested today to have like Saudi registry center to have a discussion for all those cases. So I think we need each other. We need to get some sort of well-balance for our cases, because I could, I don't need, to do a total knee replacement. I can go for some lifestyle with sport, everything, that we could avoid a lot of morbidity, mortalities as well. So we need,
we're moving towards prevention and early detection.
This is exactly, this is my word.
That's why our system is moving from intervention to prevention and from disease to health.
You are the turning point,
Yes.
in a primary care to change the whole concept from,
Absolutely.
The conventional medicine to inclusive medicine.
Yeah, holistic.
Thank you.
Thank you so much, Dr. Muhammad. Because of the sake of the time, I know that we have a lot of questions, but I would like to thank you, ladies and gentlemen and colleagues, for attending our session. And on your behalf, I would like to thank our guest speaker, Dr. Badr Bilhamd, Dr. Ammar Shimma, Dr. Sultan Ganish, and Dr. Adalia for their wonderful contribution. And I would like to extend our thanks to GSK Company for sponsoring this event. And another thanks goes to Multaqa Al-Khibrat for the well organization. Stay tuned with us. Every month, inshallah, we are going to have another session. This was the 30th session. Next month, inshallah, it will be the 31st, and we'll be keeping going with your attendance and your support, inshallah. Have a wonderful day and wish you all the best in managing our patients with COPD. Take them to the shore of safety and looking into their quality of life. with all the knowledge that we have learned today. Thank you and have a wonderful night. Shukran. We will have the dinner now here, all of us. So it's a good opportunity for networking and for socialization.